I'm going to talk about managing chronic diseases, tips for caregivers and for your loved ones. And the only thing I have to disclose is that we have a federal grant from the Health Resource Services Administration, and I've also been on the board of the Area Agency on Aging for Broward County, and I thank the team from there for arranging this great conference. So what are chronic diseases? Anybody? I'm going to talk about that. I'm going to talk about diabetes, hypertension, and heart failure. Those are the three I picked. But it can be difficulty with hearing, arthritis, abnormal blood tests, surgeries. So I went to my doctor recently, and by the way, I chose a geriatrician as my doctor because I feel I'm a geriatric geriatrician. So I thought she would understand me better. And I looked at my list of diagnoses. There are like 10 things in there. I said, I can't be this sick. Okay, but you collect baggage over time. This was time and baggage. So we're going to talk about these three conditions that I picked and how to manage it in the people that you take care of. Now, some of you may have a lot of expertise, and some of you, I hope, will gain from this knowledge. A lot has been said about caregiver well-being, so I'm not going to focus too much on that, but I do want to show you what would make a good doctor's visit as a caregiver? What could you do best to help that person have a successful doctor's visit, okay? So diabetes, it's a serious disease because it's not just a blood sugar problem. 40% of people develop chronic kidney disease, some end up on dialysis. There's twice as much risk for cardiovascular disease, so heart failure, heart attacks, go along with a long history of diabetes. And it's a huge burden in terms of hospitalization and cost. And anybody who's taken care of people with diabetes knows that it's not one problem. They have multiple other problems that go along with this disease. And one thing, just to follow what Dr. Moskowitz was saying, is diabetes increases the risk of dementia by about 1.5 times. So poorly controlled diabetes can cause an Alzheimer's type disease, but it can also affect small areas of the brain, impair the circulation. It's like a series of small strokes. So dementia increases with diabetes, and so does depression. And many of you may have noticed that already. So this looks complicated, but I just want you to have an idea. What is good blood glucose control? So what should the blood glucose be? Well, let's first look at the A1C. The A1C is a blood test or a finger stick test, which is just a measure of your blood glucose control over the last 3 months. And for healthy people, healthy older adults living in the community, it can be less than 7%. I have 84-year-olds in the clinic who want their A1C to be 6%, 6.5%. And I say no, and they fight with me. I said, you're going to have problems with low blood sugar if you get too tight and control. And for sicker patients, the A1C can be less than 8%. And in the nursing home setting, we really don't rely on the A1C by itself anymore because there are too many things affecting that level, that particular test. So what about blood sugars? What's a good morning blood sugar? Anybody for an older adult? What do you think? What's a good blood glucose level before breakfast? 190, I heard that. Well, anything up to 130 is okay, and I'm following the American Diabetes Association. I'm doing quite a bit of work with them right now. So 80, 90 is still on the low side, and we know from continuous glucose studies that people who are too tightly controlled can go down at night, and they might sleep through it, and you're at danger of losing some brain function and even damaging some brain cells. So to my patients who want to be tightly controlled, I say, you want to hang on to every brain cell you can, okay? And bedtime, you can be under 180. Okay, so don't try and be too tight, don't try and be too perfect, okay? And what about diet? What should older adults eat when they have diabetes? It's a trick question, okay? Protein, what else? Vegetables. So real food, okay? Eat real food, okay? Um, so you can have your cake and eat it, small amounts, okay? You can have your ice cream, balance the carbs, don't eat too many carbs if you're going to eat cake and ice cream that day, but real food in moderate amounts. Try to cut down the white starches, the amount of rice, pasta, and I come from an Indian background. People eat way too much rice, okay? Everything is based on rice. So now you know some of the goals, what you should aim for. Don't try and get too tight on your control, especially with frail older adults, because one of the big problems is hypoglycemia, low blood glucose levels, and then the other one is high hyperglycemia. But as a caregiver, the one thing you really need to recognize is hypoglycemia. When is that person experiencing low blood glucose? And people with dementia might not be able to tell you that. You might miss that. So on the left of this slide, I want you just to look at the hypoglycemia. What might you see? Well, they might feel more tired. They're not as talkative. They might look pale. They might hit out at you and be irritable. Okay, behavior could change. More hungry, more thirsty, vision problems. They might get shaky. So you see all those things. You might think, oh, they're upset about something. They need their anxiety medication. Well, first think of a low blood glucose. So if you see a change of behavior, try and check the blood glucose. And I'm going to talk about checking. Okay, so hypoglycemia can kill patients. Okay, so not everybody can make it, and not everybody can tell you that they're experiencing these symptoms. It's up to us to recognize them and treat them appropriately. Now, high blood glucose, very high glucose levels, less likely to be lethal, but you do feel very tired. The person might urinate frequently, so frequent trips to the bathroom, very thirsty, blurred vision. But I really want you to be aware of the hypoglycemia symptoms, especially in dementia patients. It's not that easy to recognize. You have to be very alert. Okay. So what is hypoglycemia? How low is the blood sugar? Well, there are three different stages actually. So less than 70 milligrams is hypoglycemia. Less than 54 is called clinically significant hypoglycemia, but you really don't want to get to those levels, okay? That's nothing to be happy about. And then level 3 hypoglycemia is any level of blood sugar where the person cannot help themselves. It needs an outside person or caregiver to help them. So they won't be able to ask for orange juice or reach for their candy bar. I often look at the handbags of my patients in the clinic when they have diabetes. So what are you carrying with you? What are you protecting yourself, if you have a low blood glucose? And they don't mind because I see, chocolates, mints, all kinds of things, granola bars, but they're doing something to protect themselves if they have a low blood sugar. So there are different stages of hypoglycemia. And what are the big risks? Who gets a low blood sugar? So that's worth knowing about. If you've had low blood sugars, you're more likely to have more low blood sugars, okay? That's the problem. And the brain gets desensitized. You're no longer going to get the sweating and shaking and hunger the more often the blood glucose is low. So that's the important thing, is tell the doctor, your clinician, if they've had low blood sugars. The older you are, the more medical problems, the baggage that we all carry. Dementia patients, people with renal failure, are more likely to get low blood glucose levels. And of course, as caregivers, your patients or your loved ones might not eat the same amount at each meal. You might have given the insulin and then they're not going to eat, right? So that's a problem. So, and a change in physical activity. The medications you need to worry about are the combination of insulin and sulfonylureas. So what is a It's an old diabetes medication, glipizide, glyburide, okay, Amaryl. Those are all this category. They're pills that they make the pancreas produce more insulin. But those drugs in combination with insulin can increase the risk of hypoglycemia. Okay, so not that you can never use them, but be very careful about them. And if possible, do not use that combination. Okay, so that's also up to the clinician. So how do you treat a low blood glucose? What have you guys done when you've seen a low blood glucose in your patients or your family members? What have you done? some form of sugar, right? So the rule is the rule of 15, but you can only give them something in their mouth if they're awake. In the old days, we used to have glucose paste, and we would even rub it into the mouth of somebody who was not awake. We don't do that anymore. Those people, they need glucagon, which is a hormone that raises blood glucose. But if you see signs of low blood glucose and they're alert, then you give them 15 grams of carbohydrate, which can be half a cup of juice. You don't need 12 ounces of juice with 4 sugars, okay? Because that messes you up for the rest of the day. That's too much, overcorrection. And then, or it can be applesauce, 1 cup of milk, 3 glucose tablets. You're now even allowed marshmallows, okay? So you wait 15 minutes, and that's the hardest thing, right, when you have a low blood glucose. But you recheck the blood glucose in 15 minutes. If it's still low, you give another 15 grams of carbs, which is all the things that I've listed. And then you feed the patient something with starch and protein, like a peanut butter sandwich, a half a cheese sandwich, something that'll keep the blood glucose elevated. So this rule of 15 is very important. If you have nothing in the house, look for honey, that kind of thing. Okay, but have something handy. And people who are unconscious need to get glucagon. So that can be prescribed. So glucagon is a hormone that increases the blood glucose production. And you can now get a nose spray. It used to be just an injection, which was difficult to mix. And when you're panicking, it's hard to do all that. Now there's also a hypo pen, which you see at the bottom. That's all pre-mixed, no skill required. You just inject it in the thigh or the arm, okay? And it's a life-saving drug. So for somebody who has frequent low blood glucose levels, you want to do that. Now, learning to check the blood glucose in your patients is very important if they cannot do it themselves. So you might have to, if they don't qualify for any of these continuous glucose monitors, which we now have the sensors, right, the patches where you don't have to stick your fingers. But if they don't qualify for that, you need to know how to do finger sticks. That's vital, and anybody can learn to do that, okay? But if they qualify for these glucose sensors, you've probably heard of Freestyle and Dexcom. These are patches that go on the skin. They can last 10 to 14 days, depending on the make. And they have readers, which you've probably seen on TV, a little device where you scan the sensor and you get an immediate blood glucose. And then you can go to Olive Garden and eat a big pasta, right? Or, it's low. If you eat an egg white omelet, you're not going to get much carbs, okay? But that too, in our clinic, we train the patient and the family caregivers to learn how to use this. Some of my patients don't like using the phone apps. There are phone apps for this, but they don't like using them. So there are readers and we can get very detailed reports, like how many low blood glucose levels were there? What time did they happen? Are you always high after dinner? Or are you always low before breakfast? So we know what to do. So it's a much more detailed information than just getting isolated finger sticks. And you know how we all are. When we have to do homework, we don't want to do homework, right? So patients often say, oh, I forgot my glucose log. The dog ate my glucometer, so you won't get all that information, but if they have a sensor, say, oh, you've got a sensor, let me see what they are. And now we have computer access. If they give us access, we can actually look, as I say, behind your back. I'll know what your blood sugars are doing. So to qualify for this, you have to be on insulin, generally. Or we can do prior authorizations if you get multiple episodes of hypoglycemia, if you're not able to manage for yourself, you've had hospitalizations, dangerous levels, or your brain is not aware, you have hypoglycemia unawareness. So your sugar is low, but you don't have symptoms. Then we can do a prior authorization to try and qualify you. And some insurance companies are better than others, okay? And I'll talk about that later. So let's move to hypertension. About 2/3 of people in the older age group are going to get high blood pressure. I've noticed my blood pressure is creeping up. Maybe it's putting on weight, but it's creeping up, okay? So check your blood pressure. That's the one number you need to really check, okay? And your diabetes test. Do you have diabetes or pre-diabetes? Why is hypertension so important? Some of my patients say, oh, I know when my pressure is high. I only take my medicine when it's high. No, you don't know. Okay, you think you know, but there have been studies where you have symptoms of high or low, and it doesn't correlate with the blood pressure at all. So investing in good blood pressure control, as well as blood sugar and weight control, are the three best things you can do for your health and your brain health, okay? So hypertension increases the risk of stroke, vision loss, of course heart attacks. It can lead to kidney failure, sexual dysfunction, heart failure, big problem. And I would also add dementia. Hypertension increases the risk of memory loss, okay? So these are the risks with hypertension. So what is good blood pressure control? These are the kind of latest levels. So at the bottom in the green, ideal blood pressure should be 120 over 80. How many go for that? How many have a blood pressure like that? Oh, quite a few hands. And it can vary, so don't panic. It can go up and down during the day, okay? Just relax, wait 5-10 minutes, check your blood pressure again in the seated position, okay? And between 120 to 129, it's really getting to a elevated stage, and then 130 to 139, it's stage 1. Now, for an older adult, we're not that strict. If you have diabetes, the goal is generally 130 over 80 would be a good blood pressure. But if you feel dizzy, if you feel unsteady, if you stand up and you're dizzy, okay, and you cannot tolerate some medications, then your goal could be higher, 140 over 80, 140 over 90. I wouldn't go much higher than that. And there are even studies in older people that their blood pressure, the lower the blood pressure, even in the 120s, the better outcomes, fewer strokes, fewer cardiovascular events, okay? So don't fight the blood pressure treatment, okay? It's not worth it, okay? If your doctor or your clinician feels you need treatment and, you know, you've tried weight loss, you've tried exercise, cutting down salt, if the pressure is still high, don't fight it. Just take the medication that suits you. There's so many options, okay? That's a good investment in your future health, to treat your blood pressure. Okay. And just remember, you can have very high blood pressures with no symptoms at all. I've had people walking in the clinic 200 over 120, okay, and they feel fine. So they don't know what their blood pressure is, okay? And repeated measurements are what will help us. And of course, at the same time, you should still do lifestyle changes, whatever you can do, and check your blood pressure reading at home. Get a home monitor, and then try to match it to the clinic. Here are some of the things. So when you see a very high blood pressure in your patient, what's happening? Try and figure out, is it a new medication? Are they on a new inhaler, new psychotropic medications, an increased amount of stress, excess alcohol, increase in salt intake, lack of exercise, smoking, or, you know, drugs like Motrin, Aleve, Naproxen, those help inflammation and arthritis, but they raise the blood pressure, okay? So if you're taking them at high doses and it's not necessary, try and cut back, because that can affect your blood pressure, okay, as can weight. So I want to talk a little bit about heart failure, and then I won't talk more about caregiver well-being because so much has been said at this conference. But heart failure is important, okay? So the symptoms of heart failure, try and remember FACES, F-A-C-E-S. So fatigue, okay? And limited activities, limitation of walking activities, chest congestion, edema is swelling, okay, and shortness of breath. Those are the big signs of heart failure, okay, FACES. And what are the risks of heart failure? Who gets heart failure? People with long-standing hypertension, especially if it's not well managed, you're at risk for heart failure. Coronary artery disease, heart attack, stents, obesity can by itself increase the risk of heart failure, and diabetes for sure. Other risk factors are valve disease, atrial fibrillation or irregular heart rhythms, COVID, actually, and other serious viral infections can lead to end-stage heart failure, very serious heart failure. Prolonged use of alcohol, smoking. So those are all risk factors for heart failure. So you see the kind of baggage, our lifestyle, our habits, our weight, okay, all increase the risk of these chronic conditions. So heart failure is approached by, medical assessment, echocardiogram, chest x-rays, blood tests, and then appropriate use of medication. But at the same time, always be aware heart failure can affect your function, your cognition, your clarity of thinking. And heart failure can actually make people frail, right? So what is frailty? How do you know somebody is frail? Age? Weight, so low weight maybe, very low weight. What else? What makes you think, oh, they look really frail? Gait, yeah, they're not walking well. Okay, they're tired, they're exhausted. Frailty is a bit like pornography. You know it when you see it. Okay. But you can kind of see a person and you see they're frail, okay? And a person looks a bit frail to me, and we all know it, okay? And of course, so with any condition, the social environment's very important. Like, what is the support system? Who are the caregivers? Can they manage all the medications? Can they check the weight of the person? So this is the whole comprehensive approach to heart failure. But what you need to know as caregivers is when to get help, when to call 911, when to call the doctor's office right away. And these are the things. If there's been more than a 5-pound weight gain, that means you've got to check the weight, right? It's the hardest thing to do, isn't it, stepping on the scales? I always excuse myself, oh, it's what I had last night, and, it's all excuses. If they're more short of breath, that's time to get help. The pulse rate is faster, the blood pressure is low, that's a bad sign if you have heart failure. If you need to be propped up, if you can't lie on 1 or 2 pillows, you need to sit up in a recliner, that's a bad sign. Very low energy, confusion, loss of appetite, and frailty. Advanced heart failure can make the person look like they have cancer. They're thin and frail and weak. Okay, so these are the times when you have to make even a 911 call if they can't breathe, or if they're not even waking up, or call the clinician's office right away. Okay, but this is very important as caregivers for you to know. So I'm not going to talk a lot about caregiver well-being, but I do want to leave you with what is a good doctor's visit? What can the caregiver do to make that doctor's visit or the clinician visit successful? And we heard in the caregiver panel, make yourself known as a caregiver. And as clinicians, I think many of us would agree, it's invaluable to know who the caregiver is, because you are actually the only glue between all the specialists, the ER, the physical therapy, the home equipment company. You're the only person who knows everything. Okay, the doctor's office doesn't know everything. So what can you do to make an effective doctor's visit? So carry a binder with you of the information, and we also show you some from our geriatrics workforce program. We have a booklet on age-friendly healthcare where you can collect all this information. So have an active list of medications, because your primary might not know what the cardiologist prescribed or what the neurologist did, what tests are pending, okay? What the medical equipment is, what needs authorization. An important thing is tell us what happened since the last visit. Did they fall? Okay, was there an ER visit we don't know about? Because we don't always hear from the ER what happened, okay? Tell us what happened, okay? Bring in the blood pressure, the blood glucose logs, everything with you, and write your questions down, okay? Sometimes it might take more than one visit, but write your questions down, what you need, what help do you need, and what the support system is, okay? Do you need respite care? Do you need a referral? Physical therapy is being denied. What do you need? Do you need help at home, cleaning up? Is the patient a hoarder? And there are special services for that, okay? So a good doctor's visit is when the caregiver has all this information, because the patient may not have all that at the top of their heads. And that doesn't mean just people with dementia. It can be anybody who's overwhelmed with multiple chronic conditions. So in our booklet, we give you a medication log. And remember to track all the supplements as well as the prescription medications. And drugs like Benadryl, Tylenol PM, Ativan for anxiety can cause drowsiness and increase the risk of falls. Okay, so remember that. Now, I just talked to somebody who said, since you gave that talk, I stopped taking Benadryl. I was so happy. And strong painkillers for a long period of time can be harmful. It can affect your endocrine system, your risk of falls, your cognitive ability. And anybody heard of deprescribing? Okay. It's not a bad thing. It's not that we don't care about you, but reducing the number of medications is actually a good thing. And I have patients who tell me, I'm on too much. You've got to do something about this, okay? And they're right. So there may be duplicate medications. There may be medications you had for 15 years that you don't need anymore, medications that aren't helping you or causing side effects. So deprescribing is is one of the activities that we're really focused on in the care of older adults, okay? And remember, get rid of expired medications. And lastly, it's the health maintenance. So health maintenance is like car maintenance, right? If you don't maintain your car, it's going to stop and give up at some point when you least want it, right? So this is a laundry list of, all the checkups that you can have: mammograms, bone density, prostate cancer screening, colonoscopy, etc. That doesn't mean everybody needs all those screenings, but these are general recommendations. Now, somebody with advanced illness who is maybe getting palliative care may not want a colonoscopy. We discussed that. You discussed that with us and what your reasons are. Okay, what your experience has been, and maybe we can come to a compromise. And so definitely have that discussion. And the patient and the caregiver are invaluable over time as we get to know them. We learn their stories, for one thing. We learn who they are, what matters to them, and what matters to them now. And we learn what experiences they've had before. So if we don't know your values and your goals, and combine that with your current health status, we really can't help you make the right decisions or give you the right information. But I've often had patients tell me, and I have to accept it, nope, I'm not doing that. I know you're saying that for the right reasons, but I'm not doing that. Okay, that is your wish, and those are your values, and I try to understand that, okay? So I'm going to stop here, and we've had a lot on caregiver well-being. You can look at some of these resources for caregiver well-being. We have our booklet outside on understanding the 4 M's of better care in terms of what matters: medications, mentation, and mobility. So this is called age-friendly healthcare. So thank you so much for your attention.